Welcome back to our next session. Really excited about this conversation brought to you by True Care Medical, talking about the 2020 unhappy patients, some new data looking at osmolarity in terms of visual performance, light scatter, in addition to the role of osmolarity in our clinics for dry eye. I am pleased to welcome Dr. Doug Devries, a great mentor, colleague. We've done a lot of education programs over the years. Dr. DeVries, I've always said, has been treating dry eye before treating dry eye was cool. Dr. DeVries, welcome to another Eyes On event. Thank you so much for sharing your time today.
Oh, thank you so much, Damon. It's a pleasure to be here.
So, Doug, I'm going to put you on the spot here. Monday morning, I know Monday is a typical clinic day for you as for me. First thing Monday morning, a patient comes in and has had a refractive cataract surgery. They've had some sort of advanced technology. Maybe it's a multifocal IOL, astigmatism correction. They come in and your technician does a workup, how are you doing? And they do the auto refraction and then maybe a manifest, and the patient is planosphere, they're 20/20 uncorrected, they're J1 uncorrected at near. And the patient says, my vision's not sharp, it's not crisp, it's fluctuating, I'm not happy. Did the surgeon mess up? Dr. DeVries, what did you do to me here? And the question is, do you ever see this patient, Doug?
Oh, this is every Monday morning. No, it absolutely happens on that. And, years ago, this used to be such a head scratcher saying, okay, why is this patient not happy? I mean, I'm getting great results here, but they say it's just not clear and it's variable. So no, absolutely. Absolutely. Yeah. And they're thinking at that time that something has gone wrong. They have their cataract out, but what they're anticipating, the crispness of their visual acuity just isn't present with that. So absolutely.
And we know that these advanced technology lenses, these diffractive or EDOF lenses, they need to have a healthy tear film in order to perform like they're intended, because if you don't have that, boy, they are not going to be happy campers. So tell us a little bit about just the time it takes, Dr. DeVries, to manage some of these patients that are wanting the very best vision, wanting glasses, contact lens independence. This was a study looking at the amount of chair time for these patients that it actually equated to about twice the normal amount of work in terms of office visits, actual number of minutes or hours in your office. Is this similar to what you're seeing at your practice in Nevada?
Oh, absolutely. And the reason is we've raised the bar so high. And while, we see this, and it really is completely explainable from the standpoint of even years ago when we LASIK patients, and LASIK patients would come in after surgery and they would complain of the same type of thing, a fluctuation. Well, that was just one surface that was fluctuating, and that was the corneal surface. Now we have the corneal surface fluctuating and then having an impact on the extended depth of focus mechanism, the diffraction that's in there, stretching out of those light points. Because if that light isn't good when it initially gets to the lens, you've just multiplied that, and that is a direct correlation to multiplying the time it takes with that patient to try and get that surface stabilized, so you get a vision that's stabilized as well.
So talk us through the process historically in your practice or similar ophthalmology practices regarding preoperative workup, and is there been anything missing in refractive cataract practices that we need to address?
Well, the technology that we have is absolutely amazing with the type of biometry that we have. We used to be really concerned about the ultrasound axial length measurements and the biometry that we would get there. Now that we have this laser interferometer, so accurate and so able to pinpoint the axial length, what we're missing on that is all this automation takes place, and sometimes the surface isn't looked at in a way is there disruption of the light on the surface. So we go through all these elaborate measurements, and I think unless you dig a little bit deeper, you look a little bit closer at subtleties and change, and you take some measurements, you really don't know, are those measurements that you're gathering going to be completely accurate to make that determination on what the IOL is going to be. Because we take a look at the phaco machines that we have now, so sophisticated, the femtosecond lasers, everything seems to be in place to meet that standard of that elevated bar that you're going to give that patient with the vision. Except it really has to be this intermediate point where we're taking a look and saying, are the measurements accurate? Because do we have a surface condition that can throw that off? And while it was present in just refractive surgery 25 years ago, now we're really seeing the impact that it has when that light that is beginning to scatter on the surface actually hits that premium IOL.
We've known this for decades, right? That garbage in, garbage out, and we saw that in keratoconus refractive surgery, LASIK, PRK. But with the technology, our light adjustable lenses, multifocals, whatever it is, boy, if we don't get great measurements on the back end, it's going to require a lot of, or great measurements on the front end, it's going to require a lot of work on the back end, and certainly a less than ideal patient journey. So now we talked about the past, and maybe still what a lot of practices are doing when they are not proactively trying to avoid the 20/20 unhappy patient. Now we'll introduce the star of the show, the Scout Pro, Dr. Devries. How does osmolarity change this equation for the better for our patients?
Well, when we start off by taking measurements, we look at osmolarity, then we have a good idea. Is the tear in homeostasis? Is there a balance on the surface that'll support a healthy surface, that not cause any breaks in that surface or any disruption of light in that surface, simply by looking at the salt content on the surface? And what the Scout Pro does is give us the ability to measure that very, very quickly, fit into a patient flow. And therefore we know, and we do this in our practice, we know before we ever get to the biometer, what do things look like? What did we anticipate? Are we going to need to repeat that measurement again? But it really gives us a heads up to be aware and look at what is that surface osmolarity, therefore, what is the homeostasis of the tear film? And then we can anticipate, is that going to be an accurate measurement?
So looking at why osmolarity matters for these patients that are investing time and money to get the very best visual potential met in their surgical endeavor, how does osmolarity impact these outcomes, Dr. Devries?
Well, what we're looking at is we really get a tremendous amount of these patients. It's been shown in multiple studies that patients that are coming in for a cataract evaluation have perhaps central corneal staining, they have disruption of their surface, they have a high osmolarity. And this number here, 63% of the patients have at least a mild hyperosmolarity. Well, that's significant, because when we get that mild hyperosmolarity, that means a potential going 2 standard deviations, 3 standard deviations away from the mean when we're considering the accuracy of that. And this is something that cannot be seen through our slit lamp. When we start to see an increased osmolarity, that's something that, until it manifests with more disruption and actually starts causing the breaks in the cell membranes, that we really don't see that on our patient's eyes.
So I think in the preoperative space, we really have to decouple osmolarity from dry eye. We know it's going to be one of our most important biomarkers for homeostasis in the dry eye patient. And we know that patients that have higher levels of osmolarity, more unstable tear film, they are patients that we need to treat more aggressively. But I think what's interesting here, and we'll see some data to support this, is that in the preoperative patient, yes, we want to treat their dry eye, but even if they don't have quote unquote dry eye, they don't have symptoms, they don't have staining, osmolarity, we have to treat hyperosmolarity if we want to have the best outcomes. Dr. Devries, would you agree with that?
Well, yeah, when you take a look at that, with the measurement, 63% of the patients, greater than 63%, have at least a mild hyperosmolarity, but 29% are so that you cannot observe them in another man. And that means that many of those patients are going to be really asymptomatic in terms of them reporting to you accurately that there is a potential problem.
Or the most challenging patient, they're hyperosmolar, they're pre-symptomatic, and then our surgeons push them into symptomatic dry eye. So not only are we not getting great measurements, but now they're symptomatic, not only for poor vision quality, but grittiness, irritation, watery tearing. These patients, we really need to do our best to identify them, and we can use this tool to be able to optimize our visual performance for these patients. So this is relatively new data, maybe not a new concept. I think we've all understood this, but Dr. Devries, walk us through hyperosmolarity and light scatter.
Well, when you see over on the far left and you look at, say, a grade 2 cataract, a grade 3 cataract, and then you look at normal osmolarity, as you start to get this mild hyperosmolarity of 326, it's the equivalent of a grade 3 cataract with the light scatter that occurs. So that's the real world that somebody is seeing is, and it explains that very first slide that you see when that patient is coming in and everything appears to be, good in terms of their visual acuity. But when you look at the light scatter, you look at that could have the equivalent of a grade 3 cataract. You understand why that patient is 20 unhappy at that point, because everything comes out. You say, wow, this patient should just be glowing. But now if they have that hyperosmolarity of 326, which is a pretty good number compared to a normal number down below 300, again, the light equivalent of the light scatter of a grade 3 cataract. Totally unexplainable why that patient now is unhappy. And it's not that just they had cataract surgery. They elected a premium IOL and they paid a lot of money for that. So the expectations are pretty high. But I think this explains a lot of what we have seen through the years with both just refractive surgery and now cataract refractive surgery, of how much attention to detail we have to pay up front as opposed to just worrying about it after in the post-op.
So again, with hyperosmolarity, we can't see that in the slit lamp. As that hyperosmolar state continues to cause problems on the ocular surface, eventually these patients are going to get reduced tear breakup time, corneal staining, even neurotrophic keratitis in some cases. Osmolarity is a leading indicator. Now, this is new data. This was published in 2023. And what's really interesting about this data, these are patients that had cataract surgery, and they didn't even have a multifocal or a toric IOL. They just had a basic monofocal IOL. And there were two different groups that were identified in this study. 40 patients were in the normal osmolarity group, and then another 41 patients had an osmolarity greater than 310. So that was the main difference between those groups, that 310 cutoff point. Higher than that, we know that tear film is not healthy. But then you look at the other metrics, tear breakup time, pretty much normal between the two groups. Corneal staining, negligible differences between the two groups. But now here's why this is really important to understand, is that osmolarity alone was greater dissatisfaction by a factor of 7. Dr. Devries, walk us through your interpretation of this study and what it means for clinical practice.
It's so meaningful because with a normal osmolarity, we get this and dissatisfied with the outcome. That's only going to be about 2.5% of the patients, where we have 17.1 dissatisfied with the outcome because of that fluctuation. That osmolarity is high. Now we're starting to see that is going to cause micro levels of disruption of that light, which means, and again, it doesn't really matter whether it's a multifocal, extended depth of focus, or a monofocal IOL. When you've disrupted that light at the surface, then the patient's not happy. They're going to have fluctuation, and it doesn't necessarily going to mean that just because they're coming in where they're a quarter diopter either way of plano, they're just not going to be happy. And I think really listening to the complaints of those patients when they have that, very similar to the early refractive surgery patients that would say, yes, I can see it, but it's just not clear. And I think that's what a lot of patients, they'll talk about little levels of shadowing when just not being able to see the letters with the clarity that they feel and previously in their life they had. So really I think this 7 times greater dissatisfaction, that's a number we really need to pay attention to.
And I think, again, underscoring, you can't see this at the slit lamp. So these patients come in, you refract them, they're close to plano, you put some fluorescein dye in, they look pretty good, but simply being hyperosmolar alone, that increased salt concentration on the tear film is going to cause light scatter and potentially higher levels of patient dissatisfaction. So we've had tear osmolarity in our practice for almost a decade. We've now changed over from the traditional tear lab unit to Scout Pros in our practice. What makes Scout Pro unique and different, Dr. Devries?
It's all about the patient flow and the ease of operation. You simply take the handpiece into the exam room with you. I think this is a great video that shows technician in the exam room actually puts the test card on, captures the reading that fast, and then you're watching this running time here. So put the test card on, took the test sample, the little microliters of it, and then the results come in less than 15 seconds. So it really is just ease of use. There's no running back to try to dock any of the hand pieces. You're not trying to go through that, get to the exam room, back to the base, setting the test card number, just really fast in terms of patient flow. Really, it's one of these things within our practice. It's, with 15 seconds per eye, it's a blip. That's all it is. And, meanwhile, the technician is still going on talking to the patient as well.
So Dr. Vance Thompson up in South Dakota says that, he does thousands of anterior segment surgeries a year, whether that's cataract, LASIK, et cetera. And not one of them in his practice is done without osmolarity, because he says that that's going to allow him to adjust what he needs to do on the preoperative side, more predictable healing, et cetera. Let's talk about the business model, as this is an implementation series. When someone makes the decision that for their premium patients, for their dry eye patients, even for your general clinic, that they want to incorporate osmolarity testing, what's the indication for osmolarity testing and what's the reimbursement for that, Dr. Devries?
Well, the indication, it could be really wide open, and basically is the doctor sees something, the patient says something, or a surgical eye. The reimbursement on it is really quite well with the Medicare. You're, say, buying a test card for in the $10 to $12 range. You do a test and you make $10 per eye, really, with 15 seconds of time. You don't think that's significant. And we looked back in our and did a little analysis and realized that we were doing every year hundreds of thousands of dollars and that even though it's a $10 increment that you perhaps make on each eye, that adds up over the course. When you figure that's about $20 a patient, maybe a little over $20 a patient, and to be able to identify that. And there's another aspect of this, and I found this in the very, very early days when we were doing prevalence studies with osmolarity, and that is that in those days, what we had to do is we actually had to charge the patient $25 an eye, that they knew but when they came back, they were interested in, are we going to do that test again, even though they knew they were going to have to pay. So there's a real value, not only to the practice, but to the patient, in realizing that this practice is using technology to really capture this information to give an accurate surgery.
Yeah, I think having that objective measurement is actionable on the doctor end. I think patients, at least in my clinic, they want to know that number just like they would their IOP in a glaucoma situation.
Completely.
So I think that having the objective data, having a process or protocol to be able to do that point of care of diagnostics, I think that's been really critical in not only our dry eye clinics at my practice, but also our surgical clinics and even our general clinics. We'll have a general clinic, anybody coming in to see me for any reason other than they have some sort of acute trauma. We do a speed questionnaire for every patient new to me. And then if there's any sign or symptom that's identified during the exam or during that speed questionnaire, we're going to get osmolarity testing on that day. How are you incorporating osmolarity in your preoperative testing, Dr. Devries?
We do the same thing with the speed questionnaire. So if there's any indication, again, that's where the patient says something, even though they may not be symptomatic, they are when they have a positive on the speed questionnaire. That initiates, that's the first thing that is then done, is the osmolarity testing.
And I like the speed because it identifies some things, especially with the evaporative dry eye, which is so common. Things like eye fatigue. Patients don't always correlate that with dry eye, but we know that's a classic symptom associated with dry eye disease. So then when we're using that, you'll do that. And then what does the process look like if there's hyperosmolarity noted in a patient's wanting to have cataract surgery, in particular with a premium IOL?
Well, I think this is a real important point. To identify this up front, and you saw the time that it'll take if you don't identify it in the chair time, it's different. You're going to take some time. Most of us have enough delay time between having the evaluation and having the cataract surgery that there's plenty of time to do something. And it's important to realize you get reimbursed for that time that you spend up front. You've identified something. Your practice is going to get reimbursed for the different treatments or different procedures that you do on that patient to try to normalize osmolarity, where when it's on the back end after they have problems, you're seeing them in the post-op period. And that extra time that you're spending, you're not getting reimbursed for. So what we want to do is we want to rapidly start treatment. We want to identify those individuals so that we can offer them. And now you're actually taking an actionable item on something that you discovered with the patient prior to cataract surgery. And I find it very well received by those patients. It's not like it's something where they say, well, okay, well, now I have a problem here. No, it's being identified and being addressed. And we always have plenty of time before the evaluation. And if we have to take time longer where they perhaps couldn't have it on the original surgery, that's fine. We just explain to the patient what we're doing is trying to maximize their outcome. And it all started with really finding that increase in hyperosmolarity.
So if someone comes in and they get referred to your team for cataract evaluation and they have blurred vision, which would be an indication to do osmolarity testing, or they have fluctuating vision, or they have classic dry eye symptoms of irritation, gradients, burning, and then you identify that they're hyperosmolar and maybe even decide to get some baseline testing, like how do you explain that to a patient that's thinking that their only problem is a cataract?
Well, quite often, if they've been referred in by their primary care doctor, they think they're good to go at that particular time. That's the beauty of the Scout Pro also, and the OCB and everything that we have that they may not have seen in the other practice. To say, well, we're getting ready to do surgery in your eye, so we're not leaving any rocks unturned, and that's what we're doing. We don't want to cast dispersion on anybody because that's why I think it's such a valuable, even in a primary care practice, not just a surgical practice, as you relate it to, say, contact lenses, because the same type of thing is going to take place. But it's really, to me, it's easy to explain to the patients. They understand that we've just kicked over a few more rocks where we want to do some procedures or start some medications to get the best possible measurements. And they seem to be, I would say, 90%, 95% very, very understandable of that once you have the explanation.
Now, our final question as we wrap up is, what do you do with the number, Doug? I think we identify a hyperosmolar patient, we take a history, we look at the slit lamp. How does that how does that really optimize your treatment regimen for a patient?
Well, and sometimes you don't realize how much it actually plays until you happen to be out of test cards, or for some reason you don't have it available. It plays a big part, and you just intuitively, because if you have bilateral low osmolarity, then you say, and you'd still check and make sure it meets the other findings and what you're looking at signs. It is possible under a situation to have a false negative, that you can be low on the osmolarity because of some reflex tearing. So you want to take a look. But if you get a high number, there is no false on that. A high number is a high number. And so it really does influence the way I then take a look at the patient and the approach I'm going to take. And that is going to tell them that there's a lack of balance within the tear system, and that we're going to need to address that. And then I start right away, and it's depending on how fast we may look at a procedure, to try and get balance, we may look at a therapeutic drop to get balance. And now we have so many choices, pretty easy to make sure that the patient also has access to do that.
Well, we've had a good discussion, Doug. Thank you so much about looking at that unhappy patient, and maybe we're not understanding that clinical picture completely without understanding the tear film osmolarity. Thank you, True Care Medical, and looking forward to our next session.
Thank you.
All right, we have a raffle code. Raffle code is Modern, MODERN. Doug, pleasure as always. Thank you so much, and looking forward to working with you again soon.
Thanks, Damon. Always appreciate it.